Hello, my name is Sharon Best. I'm a physician assistant and the founder of APP to APP virtual lectures. I'd like to welcome you today. We have two viewer audiences, APP to APP and My Catholic Doctor. The title of the lecture today is Autonomic Failure, Testing and Medical Management. And our lecturer is Melissa Budahazy. Melissa is a nurse practitioner who practices in the Chicago, Illinois area. She's an expert in autonomic failure, and she also treats other neurodegenerative diseases. Melissa will present the pathophysiology, clinical signs and symptoms, physical exam, as well as the clinical workup for autonomic failure. And of course, she'll cover treatment management with regard to both pharmacotherapeutics as well as lifestyle interventions that she has found to be very beneficial with her patients and can also be easily applied in the primary care setting. So the reason I'm introducing Melissa today, she is not aware of this, but she is the recipient of our first APP to APP AAA award, and that AAA stands for Amazingly Accomplished APP. And we're giving this to Melissa because she recently launched a LLC called Minding After. Minding After has a mission to bring together a community of dementia caregivers to allow them to easily access expert information and resources. So I'm going to take over the share here, and I'm going to share Melissa's website with you. So this is the Minding After website, and you can see that Melissa offers one-to-one coaching to caregivers. She's also going to be launching a podcast very soon where she will be interviewing providers as well as caregivers to allow them to share their personal stories and journeys. So Melissa also recently launched a Facebook page called the Ultimate Dementia Resource Group. I'm going to share that with you here. I will have links for both Melissa's Minding After website as well as her Facebook page in the show notes below this lecture. So as always, I would encourage you to please consider subscribing to the APP to APP YouTube page to help us to continue to help others. So now I will introduce you to Melissa Budahazy, and we'll let her take over.
Hello, everyone. Thank you so much for being here with us today. Thank you so much to Sharon for that wonderful introduction and for the accomplishment award. That's really, truly wonderful. I'm so appreciative of that acknowledgement. As Sharon had explained, I am an advanced practice nurse in the Chicago area, and I currently work at Northwest Neurology, a private practice, seeing patients with a wide range of neurological diagnoses, but most frequently dementia. Today, we are going to talk about autonomic failure, diagnosis and management, with a special emphasis on how to recognize autonomic failure sooner in our patient population. The population in the United States is aging. The number of neurologists is few and far between for the amount of people who are living into an older age and with neurological diagnoses. So my goal today is to make all of you, whether you're in primary care or in another specialty, raise the element of autonomic failure higher on your radar to recognize it faster and refer more quickly. I have no disclosures for this presentation today. And again, as Sharon had explained, we'll be talking a little bit about the autonomic nervous system and relevant neurotransmitters, some of the definitions and demographic data of pure autonomic failure, multiple system atrophy, Parkinson's, and dementia with Lewy bodies. We'll talk a little bit about history and exam, some of the diagnostic strategies from a neurological perspective and a non-neurological perspective. We'll talk about management, both from a pharmacotherapeutic and non-pharmacotherapeutic management perspectives. And finally, we'll talk a little bit about some of the resources and the latest research available on these diagnoses. So a little bit about the autonomic nervous system. We don't hear much about it in school or in clinic, but it's the automatic part of our nervous system that controls involuntary fight or flight part of our response system as if we were running from the bear, say. So it regulates those things that we don't think about: digestion, relaxation, contraction of smooth muscle, our heartbeat, and our endocrine and exocrine secretions. Furthermore, the sympathetic branch is the accelerator, primarily controlled by norepinephrine, running through those sympathetic nerve fibers to maintain our cardiovascular tone, that constriction in our blood vessels when we need to run from the bear. Now, as you can imagine, some symptoms of when our sympathetic nervous system is hyperactive, again, think of running from the bear. You have a sweating, heart rate and blood pressure up. You are trembling, blood pressure, bowel, bladder slow down. There's no time to eat or go to the bathroom when you're running from the bear. Your pupils are dilated. Think very primal, evolutionary. You're scanning that horizon for danger. Now, one important thing about the sympathetic branch, it also has another neurotransmitter, acetylcholine, which primarily focuses on helping us to activate glands. Again, when we're running from that bear, our body temperature climbs for obvious reasons, and so our sweat helps keep our body cool and our temperature regulated. In addition, we have the sympathetic branch, referred to as the rest and digest part of our sympathetic nervous system. And in that branch, acetylcholine is the primary neurotransmitter to help in secretions, heart rate, urination, and pupil function. So symptoms of that being hyperactive are your heart rate is down, you are digesting your food. So you have, bowel movements. If it's overactive, you'll have diarrhea, urination, your pupils reconstrict, teary, salivation is up again to help the digestive process. So some of the takeaways of this, without needing to exhaustively memorize everything about the autonomic nervous system, one of the main concepts that I want you to understand today is when a patient stands, I want you to think of your elderly patients. They go to stand, gravity pulls blood into their feet. It does for all of us. The way that we fight gravity is our nervous system, the motherboard, tells our heart and blood vessels, our cardiovasculature, what to do. So the nerves in our feet talk back up to our brain and say, hey, there's a lot of blood down here. We better recirculate this so we don't pass out. And then the brain then sends a signal down the peripheral nerves to the heart, in this case, to the blood vessels. So when gravity pulls blood to the feet of your elderly patients, they're of course getting less cerebral perfusion, less blood and oxygen to the brain. The nervous system is unable to detect or respond to that, to recirculate the blood. And then your patients are going to feel lightheaded and syncopal. So the motherboard, again, is sending a signal down to the nerves to that effector organ, again, in this case, the heart and cardiovasculature. The other takeaway from this slide is later when we talk a little bit about management, or quite honestly, any medication that your patient is on, when you think of adrenaline and acetylcholine and what medications your patient is on, the receptors that we have in our pupils, our gut, our bowel, our bladder are very much shared. And so when your patients are on anticholinergics or psychiatric medications or urological medications, sometimes your first step is taking away that medication to see if any of their symptoms get better, because you now know the role that that medication is playing on the acetylcholine neurotransmitter throughout their entire body. So one important concept again today is there is a protein out there called alpha-synuclein. I just wanted to briefly introduce you to this. You may see the term back on your neurology notes and the consults, called alpha-synucleinopathy. Now, alpha-synuclein is a protein. The full role of it isn't well understood, but it does play a role in neurotransmitter release in that norepinephrine, that acetylcholine. Now, the problem is when it accumulates in our nervous system. We all know in dementia, for example, in Alzheimer's, the tau proteins, they build up, the amyloid proteins build up and create a traffic jam. This similarly happens in the alpha-synucleinopathies, and point A cannot transmit down the nerve to point B. So this is the pure autonomic failure, multiple system atrophy, Parkinson's disease, and dementia of Lewy bodies all fall within this umbrella term of alpha-synucleinopathy. So I just wanted to briefly introduce you to that term because you may see it. Firstly, pure autonomic failure. One of the most important things to think about is when your patients face severe orthostatic hypotension, blood pressure tanks when they are standing. We often think about a cardiological or sometimes an adrenal reason. And my job today is to get you to think a little bit more about neurological causes. So these patients will also sometimes have bowel bladder function, temperature dysregulation. We don't know the true cause of this. It is a progressive illness. Now, the interesting thing is that pure autonomic failure is not in and of itself the end game. Typically, it will phenotypically convert into multiple system atrophy, Parkinson's, or Lewy body. Now, MSA, again, another progressive neurological illness. There are two types, MSA-C and MSA-P. MSA cerebellar type is typically characterized by imbalance, poor coordination of movements, and MSA-P or Parkinsonism type is typically more so characterized by some of the symptoms we see in Parkinsonism, a migratory jerky tremor, and for example, maybe bradykinesia or slowness of movement. But the important thing is that these patients also often have orthostatic hypotension, and it's often very severe. Now, one of the classic hallmark symptoms also is erectile dysfunction in men. The cause is unknown, but there are, as you can see, many questions being addressed in research nowadays about what could be the potential cause or causes. It's rather rare. There's about 30,000 people in the US living with it, a little bit younger in onset, 50s, 60s. But the first symptom, again, for example, erectile dysfunction in men can often appear decades earlier. It carries a rather short life expectancy, similar to what young onset dementia would be, 7 to 9 years. And that's because MSA is one of the alpha-synucleinopathies that can affect your swallowing and breathing. Your patients may present and already have symptoms like stridor or dysphagia with swallowing their pills. Ultimately, they will come down with pneumonia. Finally, Parkinson's disease and Lewy body dementia. Parkinson's disease is the most common of the alpha-synucleinopathies that are generally a little bit easier for many providers to recognize regardless of your specialty, but ultimately is characterized by these 4 criteria of bradykinesia, slowness of movement. When you walk in the room and your patient is sitting almost mannequin-like, they are not moving, there is no spontaneous movement. Sometimes they're even just holding something up in the air, maybe their cell phone or a file of papers to give you, and they're just sort of staying there in that pose. They will have a resting tremor, usually that pill roll tremor to one side. They can be rigid, and they'll often have gait impairment, those slow shuffling steps, stooped posture, reduced arm swing, and constipation can have occurred decades earlier as well. Also, orthostatic hypotension, early and often, very common in these patients living with PD. The interesting thing is we co-manage these patients with Movement Disorders Clinic. Interestingly, the medications used to treat Parkinson's lower blood pressure. So usually we in Autonomics try to stabilize the blood pressure first and then look towards Movement Clinic to help us manage the symptoms of PD. And then Lewy body dementia, as the name implies, what differentiates it most easily from these other 3 diagnoses is that severe but fluctuating cognitive impairment. They're fighting in their sleep, and there's usually a Parkinsonian symptom as well. They may have a tremor, they may be rigid or bradykinetic. And then that's a little bit less common than PD, but much more common than MSA. Now, a few notes before we head into the workup. There is more information in these slides than we can possibly cover. I would be here for a few hours just talking about exam. But again, the goal is that you recognize a handful, a constellation of symptoms that are happening to this patient, along with severe orthostatic hypotension, and it is time to refer to autonomic neurology. Some of these presentations within neuro, they are so varied and nuanced that even neurologists have a hard time. It's challenging to recognize some of these diagnoses. partly because they can also be really slow moving. We'll see patients back after 4 or 6 months to see what really unfolds and presents itself symptoms wise, to see if we can make an actual diagnosis. Collaboration with multiple specialties is, again, a really important takeaway. There are lots of referrals and non-pharmacological steps that you can take regardless of your specialty to improve quality of life and coping for your patients and their caregivers. And at times, there are maybe even a few steps that primary care can take. For example, propranolol is commonly used for a tremor. Even in neuro, we use Sinemet or carbidopa-levodopa to see if a patient improves with Parkinson's, for example, and then it's a little bit more confirmatory that a patient's living with Parkinson's. So some of the things that you might hear in history that are going to want to, raise your concern, the red flag for getting this patient to neuro, they'll say something to you that may sound a little bit acute in nature, but often for neurodegenerative illness can be very common, that it's unmasked after an infection, after surgery. And, my dad is not the same since he had his knee surgery. My mom is not the same since having had the flu a month ago. You'll hear orthostatic intolerance, lightheadedness. Maybe they're about to pass out or passing out or falling often. They're being evaluated for all sorts of causes, right? A heart arrhythmia, an adrenal standpoint, right? And nothing's coming up wrong in those specialties. It's typically worse in the morning, and all of the symptoms associated with that lack of cerebral perfusion, they're going to go completely ghost white, nauseous, shaky. They may claim that they're dizzy. Now, one area to think about is dizziness versus lightheadedness. Dizziness is true vertigo. A patient may feel like the room is spinning. They are spinning. There's usually nausea, tinnitus, or ringing in the ears associated with that. So that's very important to distinguish from the patient. If they're dizzy, that may or may not be a completely separate diagnosis. But often what you'll hear from patients is more like lightheadedness. They're woozy and need to sit down to avoid passing out. They may also say, my legs are heavy, feel like jello. They have trouble. Remember, the autonomic nervous system controls those pupil functions, the constriction and dilation of the pupil. So they may say they're night blind. They'll say they no longer sweat. They're cold or hot all the time. They may or may not say that they have a tremor. I often find that patients with something neurodegenerative are afraid, and they are often hiding their tremor. They'll keep their thumb tucked into their hand, or they're holding their arm in their lap. They're holding it so that we can't spot the tremor. So these patients know something is wrong, and there's really a lot of fear, understandably, associated with getting bad news. They are often very constipated. Again, the bowel and bladder sort of shut down. The autonomic nervous system is not innervating the bowel or bladder. You might hear erectile dysfunction from your male patients. They may or may not make the connection. So you have to ask that question and say, this might not seem relevant, but it's an important part of the nervous system. As part of this evaluation, have you experienced erectile dysfunction? Go right for it. Now, the sleep, again, they're going to be sleep fighting, nightmares, poor sleep in general. They're up several times a night. Do they have a separate sleep disorder? You might want to send them to sleep clinic. Is poor sleep a symptom of the neurodegenerative illness? Did poor sleep contribute to it? It's sort of chicken or the egg, but wait, it's abnormal. And then finally, you're listening for or asking about changes in memory, hallucinations, emotional ability. Obviously, memory changes, those can go more with Lewy body dementia. Hallucinations can be common in Parkinson's. And the takeaway for this slide, again, is everything is wrong. I have essentially done almost a full review of systems here, right? So we're looking at bowel, bladder, blood pressure. So there really are many, many things wrong here in the history. Now for exam, some of the important things here, I've given you a lot of information in this slide, and I wanted more so for you to have it as a resource for when you feel like you need to refer back to it. So a few of these things we'll go over. Obviously, you'll usually start any visit with getting your patient's vital signs. They will be normal when they're seated. The trick is getting those orthostatics, and I have a slide later devoted completely to that. You may walk in the room, they may be dressed very warmly for the season. They're going to have pretzel legs, so they're sort of double crossing their legs at the knee and the ankle to subconsciously prevent blood from pooling in their legs. And you're going to want to pay attention to their movements globally. Is there any sort of spontaneous movement? Are they shifting in their chair, crossing and uncrossing their legs, taking some thoughtful positions, writing things down, or are they just sitting there in sort of a stiff mannequin-like position? Smell test, they may have absent sense of smell from Parkinson's. Pupils may be sluggish. Remember what the autonomic nervous system's doing, controlling those muscles around the pupils. A low, weak, hoarse voice we can see in Parkinson's or MSA. Again, the cognitive test can be very quick. In your setting or in primary care, you're going to draw a clock and have them place the hands at 10 minutes after 11. Ask them 3 words to recall before that. After they draw the clock, ask them to repeat those 3 words. And if they are unable to repeat or draw that clock, I would recommend a referral to neuro. Their motor strength is usually intact, but you may see tremors, stiffness. Sensory exam, again, usually intact from the standpoint of these 4 neurodegenerative conditions, but they may have a small fiber neuropathy, maybe from diabetes, where their nerves in their feet can't quite read what's going on, if their feet are on the floor, if their feet are against the fire, if they have a cut on their feet. So that creates, again, another problem. Their nerves in their feet are not transmitting signals back up to the brain to tell the brain what to do with blood pressure. There is something called even a diabetic autonomic neuropathy from diabetes. Your patient, if their diabetes is very severe, they may not be able to manage their blood pressure. They may have gut paresis and constipation because of the diabetes. And then finally, you may notice some ataxia, imbalance for MSA. Dysmetria is that finger to nose test, and they're having a hard time actually meeting your finger. Again, that lack of coordination. And then again, your exam, you're asking about hallucinations. Most patients are actually very honest. Hallucinations, they may smell, hear, or taste, or do you notice your mom or dad or partner reaching for things in the air that aren't there? So for the orthostatics, this is very important data. You can either gather this in clinic. It's just important that your staff, whether it's an MA or RN team, gather this in a consistent routine manner, that you have a protocol in clinic, or it's important that you give patients these instructions on how to gather this data at home. Let's say your patients have told you, I'm very lightheaded all the time. I can't get out of the chair. So you'll have them gather blood pressures and heart rates. Most patients have an arm cuff at home. Omron or McKesson are good brands. And then have them, if they take any medications in the morning, namely any blood pressure meds, have them take those medications, wait an hour for them to kick in, and then instruct them to lay down for 3 minutes and take their blood pressure and heart rate, sit, and after 3 minutes, repeat, and stand for 3 minutes, and then repeat again. Have that patient remain standing for 5 minutes and have them repeat again. This way they're standing for a total of 8 minutes. Sometimes in Parkinson's, there can be delayed onset orthostatic hypotension. And so you really want to make sure that you're catching what's going on with your patient at home. Now, the diagnostic criteria, of course, for positive orthostatics, the most important one being that their systolic has dropped 20 or more points within 3 minutes of standing. I often see patients dropping 40, 50, or 60 points even sometimes. Now, some of us, depending on the specialty that you're in, when you see this happening, when you hear about some of these symptoms, lightheadedness, pallor, lightheaded when standing, right? You're going to evaluate for some of these things, or if you're in a specialty, refer to primary care. Is there a slow bleed somewhere? Is there anemia? Do they have an abnormal heart rhythm like AFib, adrenal failure? Are they just even taking in enough water? We all know our geriatric patients, they sometimes withhold water because they're worried about having to run to the bathroom. And then again, diabetes. I already talked a little bit about the diabetic autonomic neuropathy that can happen. And then is there a medication side effect? If we're lucky, maybe we just need to move a vasodilator to a lower dose, or maybe move it to the evening in collaboration with primary care or cardiology and see if the patient gets better. So this is a slide that is a sort of quick and dirty referral sheet, and I've bolded the words that are most relevant hallmark signs. Again, if there are so many varied phenotypic presentations for these 4 diagnoses, but for example, absent sense of smell, very common in PD, and it's very important for you to differentiate, was this something that may have happened after COVID, or was it present before COVID if they had COVID? And then again, the difficulty swallowing is very hallmark for MSA, and lots of them share a lot of these presentations. For example, orthostatic hypotension, some element of poor sweating, and REM behavior disorder, fighting, punching in their sleep, for example. Now, the diagnostics that we use in neurology, after they've been evaluated for all of those other differentials that I just explained, is these diagnostics help us distinguish one of the alpha-synucleinopathies from another, but the best tests for these really is time. A lot more research is needed on how to sooner diagnose one of these alpha-synucleinopathies from the other. The first one is the tilt test. Now, this is where we measure blood pressure, heart rate variability, systemic vascular resistance, and cardiac output. Now, the patient will start lying supine. They are strapped into the table, and then they are tilted up for varied time. Usually 10 minutes can be very common. The findings that we're looking for is the blood pressure dropping, usually precipitously, and without a compensatory increase in heart rate. The lack of compensatory increase in heart rate is very important for any of us. Think about when we're dehydrated, right? Or even when an elderly patient has an infection, right? Blood pressure might drop, that heart rate might shoot up to compensate because the brain detects low blood pressure and tells the heart, you better pick up the pace to compensate to get blood up to our head, otherwise we're going to pass out. So when you see that steep drop in blood pressure, 110/70 laying down to 70/50 standing, and there is no increase compensation in that heart rate, becoming tachycardic, that's usually generally very bad. The sweat test, there's lots of different ones available. The Q-SART is probably the most common you might see on testing. Essentially, it is a sort of a noxious stimuli that's introduced usually to the patient's leg that produces a certain amount of sweat or humidity that's then measured and compared against data for against some normative data for what normal sweat production should be like. And this helps us determine, again, if there's a small fiber neuropathy. Are the fibers responding to that stimulus? Are they producing sweat? Are they sending that is the nervous system sending that neurotransmitter of acetylcholine around to transmit sweat to the sweat glands? And so the finding that you'll see in autonomic nervous system failure is that there is pseudomotor or sweat gland failure. The pupillometer, again, we had mentioned another part of the nervous system, the sweat glands, the pupil function, they're automatic things our nervous system just triggers when needed. So we measure baseline pupil size, how quickly it constricts to light. It almost looks like a camera flash. We flash in their eyes. And then when we remove the flash, how quickly the pupil redilates. And the finding that you'll see there is usually something like sluggish response. The central nervous system is just not able to dilate and constrict the pupils as quickly as needed, and hence you get those visual complaints from your patients. Some of the other things that are used in neurology and in other specialties are a skin biopsy. We get 3 small pieces of skin after injecting an anesthetic to look for an accumulation of that alpha-synuclein protein. Now, some of the other labs that we get in neurology, the biggest one is we're getting those catecholamines, right? We're measuring that level of norepinephrine. And sometimes we can tell based upon that lab how what the measurement of the norepinephrine is when they are first laying down. We redraw blood again when they're standing. Sometimes, depending on the change in their level of norepinephrine from supine to stand, we can sometimes differentiate one alpha-synucleinopathy from another. We sometimes draw other labs, again, if they weren't done, if the patient had already shared their symptoms with primary care, to see, again, what other differentials might be going on. Some of the things on MRI that we look for are just global atrophy of the brain tissue, especially in dementia. There's a hot cross bun sign, a cross that looks like you have 4 hot cross buns in a bakery box. That can be a hallmark of MSA. And then finally, the dopamine uptake scan. There is a picture to the right here. The second picture from the right is a normal DAT scan. You are looking at the nuclei, which should be comma-shaped or bean-shaped. And then that fourth picture depicts an abnormal DAT scan, usually a hallmark of Parkinson's disease, where the nuclei look a little bit more dot or period shaped. Ambulatory blood pressure monitoring, I absolutely love, especially when there are patients, maybe it's difficult for them to get, they don't have a blood pressure cuff at home. It's hard they live alone. It's difficult for them to follow instructions. Maybe there's some cognitive impairment. And so what you can do is in autonomic neurology, sometimes primary care or nephrology, anywhere around you that as a provider that you can offer this service to your patients, they are set up with a blood pressure cuff and it is turned on. They wear it for 24 hours and then they return the cuff and you can download the results to see truly what is going on. They can keep a basic diary. It doesn't have to be exhaustive. When they went to sleep, when they woke up, when they took their medications, in which they were, if they had a headache, if they exercised, things like that. And there are some other tests available only in research, like an iron uptake study in the brain. I'll talk a little bit about that at the end. So as we head into treatment, something for you to keep in mind for those of you who are in a non-neurological specialty, there's no surprise here, especially for APPs. This takes a comprehensive plan. We don't have one intervention. There is one really good medication, but it's usually a comprehensive plan that we need, pharmacotherapeutics plus lifestyle changes, trigger avoidance, a rehabilitative approach, and optimizing comorbidities if they exist. Now, treatment focuses, as with most progressive neurodegenerative illnesses out there, on expectations and symptoms management, expectations for both caregiver in terms of what they are able to handle and cope with, where they may need more help, as well as the patient and their safety. These are slow-moving diagnoses. So, patients may return back to you from neuro, right? They're not really sure what's going on. They're thinking of a few of these diagnoses. For these 4 diagnoses, these alpha-synucleinopathies, a lot of the time they are managed in a similar manner. For example, blood pressure, stabilizers, pressors, regardless of which one of these 4 neurodegenerative illnesses we think people have. Autonomic neurology is usually going to place patients on a pressor first. So some of the interventions are similar, which can be reassuring to a patient who can have a lot of anticipatory anxiety about what is my diagnosis, what is my diagnosis. Now, we do, of course, customize the patients respond to different meds differently, so that will be customized. And as with anything, anytime you're selecting a medication, there's usually more than one in a category. We don't have the luxury of picking from too many medications in Autonomics, but we do, of course, consider things like allergies, using our critical thinking when thinking about what other comorbids they have, patient preferences, past things the patients have tried, but sometimes we're also just relying on trial and error and initially starting with discontinuing what we think may be an offending agent. As I had mentioned, if a patient's taking a vasodilator in the morning, as they age, it may be too potent for them. So maybe we start with cutting their vasodilator dose in half and see how they do. Our first category of medications that we choose from, or three separate categories rather, each of these medications. Midodrine is a pressor to stimulate contraction of that vascular smooth muscle. It is a short half-life, it's 3 times a day. When patients often have severe orthostatic hypotension, I usually in Autonomics will put them straight up to 10 milligrams TID. There are some funny, side effects. Think about where the alpha receptors are in our bodies, right? In the autonomic nervous system, the sweat glands, goosebumps, the bladder receptors, right? So patients can have goosebumps, itching, urinary urgency. And then you definitely want to take this medication, as well as droxidopa down below 3 hours before bed. The pressor effects of these medications means that you want to avoid taking a nap right after you've taken them or going to bed, so that you can avoid that supine hypertension, that really high blood pressure. And so for these reasons, we recommend patients with autonomic failure on midodrine or droxidopa sleep with the head of the bed elevated. Fludrocortisone, you may recognize that name. It's a corticosteroid. We produce it, in our adrenal glands. It helps us retain sodium and keep that electrolyte and acid-base balance. This is usually dosed once a day. It's long-acting, so there's less risk of supine hypertension or time of day parameters to take your last dose. Now, because it's of its steroid effect, you're going to want to avoid it in diabetes, heart failure, osteoporosis, but that risk benefit should always be weighed with the patient and that treating physician. For example, it's less than ideal to put a female with osteoporosis on fludrocortisone, but you have to weigh the pros and cons. If this patient's blood pressure is tanking and they will fall because they break a hip, they're going to fall from orthostatic hypotension and break a hip. So the pros and cons, risk benefit really need to be carefully weighed. Now, droxidopa, think about what we are treating. These are peripherally acting medications, midodrine and fludrocortisone. Midodrine is contracting the smooth muscle. Fludrocortisone is causing us to retain sodium. So they're working different ways than on the central nervous system. Remember, the problem is the motherboard, not the inability to recognize this orthostatic hypotension and respond. So droxidopa, working on those dopamine receptors, central nervous system receptors, to press up that blood pressure. Now, there's no clear way to, transfer this patient if they were on max dose of midodrine, for example, or fludrocortisone, sort of like the morphine calculations that we do to change a patient to or from morphine. Droxidopa, really, if there is severe orthostatic hypotension, we may go right to 300 or 600 3 times a day, with a little bit of a slower titration, but ultimately knowing that patients are going to need a rather high dose. Of course, the side effect you're looking for is hypertension. So that's why we do a little bit of a slower titration. And then again, a very nuanced approach is sometimes these patients do need an antihypertensive at night to offset effects of the droxidopa during the day. It can be very expensive despite it being generic. So you're going to want to have your staff help patients maybe find a savings card, or the best way to access this medication is the access problem that we typically have with this medication. Some of the others that we use are pyridostigmine or mestinon. It's actually used for other neuromuscular illness. It's generally very poorly tolerated. Again, think about what's happening here. The mechanism of action is to promote that parasympathetic function in the body. It's a cholinesterase inhibitor so that more acetylcholine lives in the body, right? Is sort of floating around in the nervous system. So it really has a lot of side effects and generally is very poorly tolerated. Patients have come to us on stimulants to boost up their blood pressure, not the safest option in patients, elderly patients, geriatric patients who may or may not have had or at risk for cardiovascular events. And then sometimes we refer our patients from Autonomics to movement once we've stabilized their blood pressure. Movement disorders will give them a Cinemet trial to see if there are tremors, their stiffness, bradykinesia improve, and the Cinemet challenge will then confirm, for example, if the diagnosis is Parkinson's. Often with patients living with MSA, the MSAP type or Parkinsonism will not get better, and that helps us differentiate between MSAP and Parkinson's. So what you can do, again, whether you are in primary care or in another specialty where everything is wrong in your patients, they have severe orthostatic hypotension, some of the things that you can do are exercise, hot shower, and a big meal. Those can be triggers to this orthostatic hypotension. Think about what happens after these things. The blood vessels dilate, or the blood shunts to a gut after a big meal. So there's less cerebral perfusion, right? So less hot showers, put a stool in the shower. We of course still want the patients to exercise, but maybe a little bit more safely on a stationary bike. Have 5 small meals throughout the day. Slow position changes from laying to sitting, dangle on the side of the bed for 60 to 120 seconds, 1 to 2 minutes. All the fall precautions that we all know as APPs, night lights, stapling cords to the rug, non-skid shoes, for example. Elevating the head of the bed, that can help reduce needing to urinate multiple times at night and avoid supine hypertension. Avoid infection. These are the 10 germiest parts, right? Transmitters of infection. Increasing salt to see if we can raise that blood pressure, right? So we're increasing blood volume, even though the problem is central in the motherboard. After we eat something salty, right, we drink a lot of water and then we feel bloated. So we're trying to recreate that similar effect with pressing out that blood volume with salt, if that is safe for the patient to take in, given their kidney or heart function related to comorbids. Knee-high compression, abdominal binder compression. Again, we're manually shunting that blood up to where it belongs. And encourage your patients to drink water. Come up with a plan for toileting every 2 hours if they're worried about having to run to the bathroom. Manual maneuvers, literally when they go from sitting to standing. Pump those feet, calves, glutes, fists to get that blood moving again. Remember, the motherboard, the brain is not sending signals to the cardiovasculature to adjust blood circulation when you change positions from laying to sitting to standing. So we're using a combination of trigger avoidance, over-the-counter remedies like salt and manual maneuvers to reshunt that blood up. And then I always refer patients when there's concern for neurodegenerative condition or orthostatic intolerance, sending them to physical therapy or putting them on an endurance training plan, maybe with cardiac rehab. Cardiac rehab will accept these patients, even if they haven't had heart surgery or valve replacement or COPD. In those settings, those patients get a lot of support, monitoring, and goal setting. And we instruct PT to aim for the American Heart Association guidelines that they instruct for everyone to follow with exercise guidelines. Referrals, again, PT for endurance training. You can refer them for pelvic floor therapy when there's bowel bladder challenges, when they haven't responded to the usual algorithm we use for constipation, starting with psyllium fiber on up to laxatives and stimulants, etc. Dysphagia, if they're already having trouble swallowing their pills, I already have to crush my pills, it is time for a swallow study and speech therapy. If they have a REM behavior disorder, kicking, fighting, punching in their sleep, night terrors, snoring or sleep apnea, where the partner notices they're not breathing for long periods and has to elbow them to wake them up, I would send those patients for a sleep consult to see if there's maybe a separate sleep apnea going on that you're going to want to treat. Sometimes when patients already have inspiratory stridor, that can be common in MSA. Remember, that involves the swallowing and breathing muscles. Stridor, you can easily Google that online. It'll be a high-pitched whistling sound. And often those patients will benefit from nocturnal O2. They can be evaluated in pulmonary for that. Any sort of motor deficits, tremor, PTOT, they'll get weighted spoons. For Parkinson's tremor, weighted forks, trained on ways to put their clothing on, things like that around the house, and Tai Chi is really great for balance as well, especially in Parkinson's. Now, if there's imbalance, whether they have ataxia or ugly looking gait that you're worried about falls, or PT with their stoop shuffling gait, again, PT is really great with evaluating for assistive devices and first promoting independence rather than giving them assistive devices too early and making them more dependent on them. PT is excellent at that, so I trust their judgment on that. And then the other thing to consider is the role of the caregiver, right? These are neurodegenerative illnesses that take a lot of multidisciplinary effort and collaboration from many providers, as I've just listed. And so you're going to want to check in with the caregiver, make it a team effort. Mr. Smith, I want to talk to your wife a little bit about her perspective on how things are going and how she's doing. We're all a team together, and we need your wife to be well so that you stay well. Maybe the spouse or child or family member or friend needs a referral as well. The patient might need they can do support groups together. I'll get into that a little bit later about support groups. Jerry Sykes social work consults for both of them, family meetings. We have to support the caregivers for these diagnoses. They need a full cup in order to, share with others in order to care for others. And I wrote a little note here: a side effect of a medication may worsen another symptom. I'm not sure why I put this on this slide, but I think, again, I'm just trying to drive home the point of, in your specialty, maybe you have the patient on a medication. Now that you understand the roles of these neurotransmitters and where these receptors are in the body, people's connected to the gut, to the bladder, to the heart and blood pressure, right? Is it a medication I have the patient on that maybe I need to think about cutting back? Maybe I'm bottoming out their blood pressure and making it worse. Now, for coping and coaching, this is also a really important part of our care in neurology, psychiatry, primary care. Do we need to consult psychiatry or social work? Patients, as we know, for any of you who treat any chronic condition, stroke, high blood pressure, diabetes, COPD, depression rates are through the roof. Secondly, we know the geriatric population lives with high rates of depression that are untreated. And so I always, when I notice that that's going on, I try to encourage them to treat it and give the appropriate referrals, because that certainly will not help them cope with this new neurodegenerative illness. Now, after we start treating blood pressure, patients may still call me and say, I still feel terrible. The important thing is to start with evaluating what are your orthostatics. Now, at this point, you can truncate the orthostatics. We no longer really need the laying, sitting, standing blood pressure and heart rate. We may already know that they have a neurodegenerative disorder. Their heart rate does not compensate. So I really have them take a shorter version of orthostatics and just do a sit stand. Sit for 3 minutes, take your blood pressure, stand, wait 3 minutes, retake your blood pressure. If they are better, right, I reassure them and say, you dropped 60 points on the tilt test. Now you're only dropping 15. Let's increase your midodrine a little bit, or your droxidopa. Are you taking in salt? Are you using compression, right? So we're asking what else is going on. What is the true symptom that you are worried about? You know, I'm still running to the bathroom. Maybe they need pelvic floor therapy, right? So there might be something else going on. Again, the reassurance, the problem solving, whether that's a referral or, you know, I'm freezing all the time. It's beautiful out. I'm not sure what to do, layering up, right? Just basic problem solving and coping with the patient. There are two researchers who I truly love, McGonigal and Jameson. They're PhD researchers working on this concept of benefit finding. No matter how bad things are, what is the upside? What have you learned about yourself? That is information. It's easier to spiral down than up, right? Into that positive thinking. Focus on their capabilities, what they can do. Maybe they couldn't get all their errands today, but you can finish them tomorrow, pacing what the week looks like. Finally, I also really love motivational interviewing. Miller and Rolnick are the gurus on that. So this example that I'll try with you is what is one thing you can try for stress management? And the patient may say, well, I can go on daily walks with my sister. And I'll say on a scale of 1 to 10, what is the likeliness that you can do that, 10 being the most likely? And they'll say something moderate, like I'm 6 out of 10 most likely to do it. And I'll say, that sounds great. Why didn't you give yourself a 2? What makes you give yourself a 6 instead of a 2? And what that does is it forces them to focus on their strengths. My sister and I have a great relationship. She's very motivating, and I feel really good that I'll achieve this goal of a daily walk with her. In addition, other things that you can do are providing some of these resources to patients. In neuro, there is a lot to do with these patients. For the most part, we try our absolute best to connect these patients to these advocacy resources, but this is also something that anyone can do, especially in primary care. APPs are excellent with sharing resources with patients. I find that we're really well prepared with doing that. You know, it gives the patient an extension of support outside of our 4 clinic walls and helps enhance their coping. The MSA Coalition is an excellent organization. They offer support groups, an annual conference that is free and very much tailored towards the patient, very practical. They have a session on doing chair exercises to music, but they are also a great research tool to look at the latest research as well. PMD Alliance, for obvious reasons, patients living with any sort of movement disorder, tremor, whether it's from MSA or Parkinson's, also really great fundraising, support groups. Getting involved in a walk in your Alzheimer's Association is excellent at this, getting involved in the annual walk run events. You can meet other people and other caregivers living with these same illnesses, exchange phone numbers. It can be very powerful. Mayo Clinic, of course, a lot of the researchers for the alpha-synucleinopathies work at Mayo. In Rochester, Florida, for example, NYU, Vanderbilt, North Shore University Hospital System, where I used to work, in Autonomics in Illinois, and University of Texas is where a lot of the experts in Autonomics are and have excellent providers and autonomic testing. Now, finally, what I'd like to encourage our providers to do is start a support group. Now, many of you have maybe already done this for those living with chronic kidney disease or diabetes in your specialty. Now, I started one for those living with autonomic failure, even if they weren't clear on what their diagnosis would manifest into later, MSA, PD, or dementia with Lewy bodies. I just allowed patients who lived with autonomic failure to join. You're going to want to keep it to less than 10 people to give everyone a chance. My group was just local. But depending, there is potential to grow it to regional or maybe nationwide, but some of these advocacy groups have, keeping a support group local and small is sort of the whole purpose, living within your community. What are the resources in your community? Maybe meeting up, exchanging phone numbers they feel safe to do so, right? And I invited speakers for mine. I had about 6 meetings. I invited speakers for the first 30 minutes and then for the last hour. It was a free-for-all. The patients could focus on that topic of that speaker or take it in whatever direction they wanted to. The floor was theirs. I found that some of the discussions we had were really beautiful and wonderful. There was one patient who asked, what do I even look for when looking for a care community that can help me transition from independent to assisted to memory care if I were to need memory care? And without my even answering and giving any advice, another patient chimed in and said, I know, I just searched, I was just looking at a few care communities with my family this past weekend, and he walked through what he loved and what he didn't love about some of the communities he had visited. And it was so helpful for everyone to learn that, you focus on problem solving. The caregivers can join the patients, and you can do this any which way, depending on your patient needs, every 2 weeks or monthly. Now, I also involved social work. I was able to hand this group off to social work. They are able to bill for it. That's something where it's very much within the will of social work to continue to hold those support groups. So just a little bit of advice if you had planned on starting your own. So in summary, for primary care or another specialty, if there are multi-system deficits, neurodeficits, and severe orthostatic hypotension based upon the results you get from those orthostatic instructions that you give your patients, it is time to place that autonomics referral now. In the meantime, what you can do is proceed with lab workup to rule out those differentials we had talked about, anemias, for example, and get those referrals going. They can certainly start physical therapy or pelvic floor therapy, a swallow eval if there's difficulty swallowing, follow that constipation algorithm, and get the patient to neuropsychology to parcel out if there are memory or personality or behavioral changes. What is a neurological symptom? What is a psychological symptom that can be treated and optimized if there's a depression or anxiety, to make it easier for neurology to diagnose truly what's going on from a neurological standpoint. And then the approach is medication plus lifestyle changes. So again, primary care, any specialty, going through that lifestyle changes slide, avoiding triggers, compression hose, etc. And then the educating and enhancing coping, right? Offering advocacy resources, support groups is something that we as APPs, I think, are excellent at doing. Now, some of the latest research that has been going on is there is a medication called ampreloxetine. It's a long-acting norepinephrine reuptake inhibitor. So there's more norepinephrine in the central nervous system, in the sympathetic nerve fibers, to improve constricting those blood vessels to keep that blood shunted up for cerebral perfusion. Now, there are some research studies going on to, again, hopefully quicken the pace with which we can differentiate one alpha-synucleinopathy from another, treat sooner, enhance coping and quality of life sooner. There are some neurofilament light chain that we can see in spinal fluid. And it namely helps us distinguish MSA from Parkinson's. MSA Parkinsonism can look very similar to Parkinson's disease. There is iron accumulation that occurs in the brain. Again, that can help us depending on the amount of iron that has accumulated in the brain, and the parts of the brain help us differentiate again from MSA and PD. And also the biopsies that we take, those skin biopsies, to look for the alpha-synuclein protein. There's some research going on to quantify exactly how much alpha-synuclein you have, and does this amount of alpha-synuclein correlate more with Parkinson's disease? Does this amount of alpha-synuclein protein in your nerves, is that more consistent with MSA, for example? So there really is some exciting research going on treatments and diagnostics for the alpha-synucleinopathy, so keep an eye out for that. In summary, the alpha-synucleinopathies, pure autonomic failure, which sometimes converts into multiple system atrophy, Parkinson's disease, or dementia of Lewy bodies, they are incurable, progressive neurological illnesses, all of which require a lot more research in terms of the diagnostics and treatment and causes as well. And then it is time to refer to autonomic neurology when there are multi-system complaints, everything's wrong in that review of systems, and there's some sort of connection with the autonomic symptoms, right? The pupils, nighttime blindness, can't adjust to light or dark, orthostatic hypotension, the cardiovascular system and brain are not connected, temperature regulation, bowel bladder dysfunction. Think of where all these alpha and beta receptors are, right? Multi-system complaints with neuro deficits like slowed movements, tremors, imbalance. It is time to refer them to neurology, at least neurology, if not autonomic neurology. And again, as of today, they're incurable, but we have a multitude of pharmacotherapeutic plus non-pharmacotherapeutic interventions, again, which primary care or many other specialties are well positioned to introduce patients to early in the course, even before they see neuro. There's lots of disciplines and collaboration that goes on among providers. Again, in neuro, I would never change a cardiologic medication without reaching out to cardiology. And most often, I think many of you find we're all generally very appreciative when we reach out, especially to explain a little bit about a little known diagnosis so that we can all be on the same page together on what the plan is. And research is being done to look at how we can more quickly differentiate these diagnoses, diagnose sooner, treat better, and better yet, even prevent the causes. That is all that I have today. Those are my references. And I am so truly grateful to be here with you today. And thank you so much again to Sharon for having me and for my Amazing Achievement Award. I'm so truly honored. Thank you.